I'm excited to introduce Dr. Michael Bishop, Director of the David and Etta Jonas Center for Cellular Therapy at University of Chicago. Dr. Bishop specializes in the diagnosis and treatment of lymphomas. In particular, he cares for patients with hematologic malignancies that have not responded to the first-line treatments. An expert in hematopoietic stem cell transplantation and cellular therapy, Dr. Bishop and his team are working to address the unique social, economic, psychological, and biological issues that patient faces while undergoing this treatment. Today, Dr. Bishop will present the latest advances in CAR T-cell therapy in hematologic malignancies. So with that, please welcome Dr. Bishop. If you have any questions, please leave your questions in the Q&A chat from the Zoom control. We will address your questions after his presentation. You can leave your questions either in English or Spanish. Dr. Bishop, you're on the stage.
Well, thank you, James, for that very kind introduction. And I am pleased to be able to present to you today a little bit about updates on CAR T-cell therapy. These are my disclosures. It is important. I actually do a lot of consulting, and I'm on advisory boards for a number of companies that are involved in cell therapeutics, but none of the discussions today will involve off-label use, and I will hopefully keep within the boundaries of my expertise. So for those of you who are not familiar with CAR T-cell therapy, CAR T-cell therapy has now been available in clinical practice for approximately 15 years. So it's a relatively novel therapy. CAR stands for chimeric antigen receptor. It is referred to as chimeric from the Greek mythology of the chimera, which was a mythological creature which had different body parts: the head of a mountain goat, the head of a lion, the body of a horse, and the tail of a snake. And in chimeric antigen receptors, we take various components of the immune system and bring them together. And what you're seeing down here in the lower part of this illustration, where I have the arrow, that is a chimeric antigen receptor. And this has revolutionized how we have treated hematologic malignancies, particularly leukemias, lymphomas, and multiple myeloma. And so what it does is we actually collect the white blood cells from a patient, known as a process known as leukapheresis. This is done as an outpatient, and the cells are taken, those leukapheresis stands for white blood cells, and we separate the white blood cells into their lymphocyte components, and we select out from that the T lymphocytes. And those T lymphocytes are placed into culture, they're activated, and then they are genetically modified by introducing a virus into the culture. And that virus infects the cells, but it doesn't damage that. And it carries genetic material that causes the T cells to express this chimeric antigen receptor. And you can see the receptor is on the outside of the cell. And then on the inside of the cell are components that once this genetically modified T cell engages with a cancer cell, it activates that to attack the cancer cell. So they grow up large numbers of these, and they and the laboratory returns it to the CAR T cell center, and patients, prior to receiving these modified T cells, they receive what is referred to as lymphodepleting chemotherapy. And this lymphodepleting chemotherapy is more intensive than standard chemotherapy, but less intensive than chemotherapy that is used for a stem cell transplant. And it serves two purposes. It it wipes out the immune system to give the CAR T cells a competitive advantage because lymphocytes in the body compete for resources. So this provides all of the resources to the modified CAR T cells. And it also provides tumor control. And then once the lymphodepleting chemotherapy is completed, the modified CAR T cells are infused intravenously to the patients, and they almost go immediately to work attacking the respective disease and hopefully resulting in an improved outcome. So that's the CAR T cell process. And so I wanted to give some updates, and where CAR T cells have been used most extensively is in non-Hodgkin's lymphoma. And matter of fact, the first approvals for CAR T cells were in non-Hodgkin's lymphoma. And this came from clinical trials that were initiated in the mid 2000, approximately 2015 to 2017. And there were three major studies using three different CAR T cell products. There's a Zuma-1 trial, which I'm going to use the abbreviation for this, is what we refer to as axi-cell. There's a Juliet trial that used Tisa-cell, and there was a Transcend trial that used Lysa-cell. And these were all in patients whose disease had been multiply relapsed or refractory to standard therapies, and specifically looking at the most common non-Hodgkin's lymphoma, diffuse large B-cell lymphoma. And in this group of patients, the median survival was 6 months, and therapies available at that time could result in only a 25% overall response rate and a less than 10% complete response rate. But we now, in an update, we now have 5-year data from all three of these trials. And what can be demonstrated in this, and again, where there was a median survival of 6 months, we now see that median survival is approximately 3 years, and that we're seeing at 5 years that these patients are able to maintain these remissions. You see a flattening of these curves. And for the first time, we're able to say that CAR T cell are curing patients with relapsed and refractory diffuse large B-cell lymphoma. Because of the great success of CAR T cells in multiply relapsed patients who had received 3 or 4 lines of therapy, the question was asked is whether CAR T cells could be moved up in the treatment paradigm. And there were 3 major trials that looked at CAR T cells as second-line therapy in high-risk diffuse large B-cell lymphoma. And high risk was defined as either not responding to first-line therapy or recurring within 12 months of first-line therapy. And these 3 trials, again, use the 3 CAR T-cell products that I referred to before, Zuma-7 with axi-cell, Belinda with Tisa-cell, and Transform with Lysa-cell, and compared it to what was at the time the standard of care for these high-risk patients in the form of an autologous stem cell transplantation versus the respective CAR T-cell products. And what these 3 studies demonstrated, 2 of the studies, Zuma-7 and Transform, demonstrated that CAR T-cells were markedly better than the standard of care with autologous stem cell transplantation. And that this, unfortunately, the Belinda trial, for a number of reasons that we don't have time enough to explain, showed that the 2 were equal, But for these other two studies, the CAR T cells were markedly superior, and this led the U.S. Food and Drug Administration to approve axi-cel and liso-cel as second-line treatment for second-line treatment of high-risk diffuse large B-cell lymphoma. And this has been adopted as the new standard of care for these high-risk patients. CAR T cells have been used in other lymphomas, specifically in the ZUMA-2 trial. They looked at the use of axi-cel in patients with relapsed and refractory mantle cell lymphoma who had failed 2 lines of standard therapy, including a Bruton tyrosine kinase inhibitor, which is considered the standard of care in second-line treatment. And in this patient population, again, median survival is expected to be less than 1 year, and response rates would be less than 50%. Yes, yet CAR T cells, even looking at an intent to treat analysis, demonstrated an overall response rate of 80% with a complete response rate of 55%, far exceeding the expectations for this group of patients. And these responses tended to be durable, and it led to the approval of axi-cel for relapsed and refractory mantle cell lymphoma. And you can see from these Kaplan-Meier curves that the responses were durable. The middle line is all patients. These are patients who did not achieve a complete remission, but if you look at that 55% who did achieve a complete remission, you can see that median duration of response has not been reached and ongoing at greater than 2 years. So these are very impressive results for a very difficult group of patients. CAR T cells have also been looked at the treatment of low-grade lymphomas, such as follicular lymphoma and marginal zone lymphoma. And in this situation, when we look, this is again with the axi-cel CAR T cell product, when we look at progression-free survival, it's very impressive with follicular lymphoma, although not as impressive with marginal zone lymphoma. However, when you look at these relapse refractory patients in terms of overall survival, you're seeing with follicular lymphoma a 90% overall survival rate, and even with the 97 the marginal zone lymphoma, and with the follicular lymphoma, we're seeing a greater than 75 overall survival. So very impressive results in terms of it with low-grade lymphomas in this group of very difficult patients to treat. Another product that has looked in low-grade lymphoma is Tiza-cel. And again, we're seeing, and this is in follicular lymphoma primarily, and again, you're seeing event-free survival rates in over 80%, 60% approaching 1 year. And again, this product has been approved by the U.S. Food and Drug Administration for the treatment of relapsed and refractory follicular lymphoma. Another major advancement is in the use of CAR T cells in acute lymphoblastic leukemia. It is known that for patients, both adult and pediatrics, who relapse after first-line therapy, that median survival is approximately 6 months. And based upon work initially done at the University of Pennsylvania, a large international trial using the Tiza-cel product was looked at in children and young adults with relapsed and refractory B-cell acute lymphoblastic leukemia. 92 patients participated in this study with an age range of 3 to 21 years of age. And matter of fact, the patients had been heavily pretreated with a median number of prior therapies being 3, including nearly half of the patients having undergone a prior allogeneic stem cell transplant. And remember what I was saying is that the median survival for this expected median survival for this patient population was 6 months, yet in this trial, 90% of patients were alive at 6 months, and 3/4 of the patients were alive at 12 months, and median survival tends to be less than 1 year. Now, multiple studies had demonstrated that in this multiply relapsed situation, that the results appeared to be better than standard of care. And this led to an actual randomized trial, which permitted investigators to choose the standard of care, or they were randomized to receive CAR T-cell therapy. And you can see for the median overall survival for the standard of care arm is less than 6 months, and yet for the median progression-free survival for those patients receiving CAR T cells, it's going out to 12 months. So it's nearly, when looking at median progression-free survival, it nearly triples the expected progression-free survival CAR T cells over standard of care in relapsed and refractory multiple myeloma. Now, based upon this, the same question was asked. So if we wait for multiple lines of therapy, can we act, and similar, I apologize, similarly, another study using a different CAR T-cell product, what is known as cilta-cel, showed similar results with a 2-year overall survival of 75%. And there is a newer CAR T-cell product that is known as anito-cel, and it is shown in 100% overall survival, including 76% of patients achieving a complete response. And when looking at progression-free survival with this newer CAR T-cell product, we see that for all the patients, that we're getting out to 27 months in terms of progression-free survival. So these newer products continue to improve the outcomes in relapse and refractory multiple myeloma patients. Now, what I was referring to is that what people wanted to know, if it's in relapse and refractory, can we use this in earlier lines of therapy and see if we can improve this? And most recently, CARTITUDE-4 was reviewed by the Food and Drug Administration this past spring, and what CARTITUDE-4, as looking at second-line therapy with a CAR T-cell product versus standard of care, again in a randomized fashion. And you can see clearly in terms of progression-free survival that the use of the cilta-cel CAR T-cell product resulted in a significantly higher degree of improved progression-free survival as compared to 12 months. And this is in second-line therapy. And you can see the median progression-free survival of 12 months here. So, and this has not been reached with cilta-cel. Similarly, using identical study of ide-cel as second-line therapy, we can see that looking at progression-free survival improvement in with the use of this ide-cel CAR T-cell product as standard of care, again in second-line therapy. Both of these studies, after being reviewed by the U.S. Food and Drug Administration, led to their approval in the second-line therapy. So, in brief, there's been markedly significant advances in the treatment of advanced hematologic malignancies and improvement in outcomes through the use of CAR T-cell products. And I'd just like to let you know that the University of Chicago had participated in almost every one of these trials that led to these U.S. Food and Drug Administration approvals. And we're very proud of the fact that we're able to provide cutting-edge therapies for our patients. And I just want to share a little bit about our program. So we are a combined stem cell transplantation and cell therapy program. And our mission is to assure that patients receive the best possible care while undergoing treatment in the University of Chicago Medicine Transplantation and Cell Therapy program. This is achieved through consistent patient care. And how consistent patient care is achieved is through a research protocol whenever possible, program policies and guidelines, routine review of our outcomes to quickly implement changes when we see that things are not going as well as we'd like, or when new modalities permit the improvement in our outcomes, and then clinical standard operating procedures. And all of these are interrelated and result in improved patient outcomes. We have a rare situation where we have a totally integrated program. And so that we work with our leukemia program, our multiple myeloma program, our lymphoma program, and we are also doing cell therapy for solid tumors. And each one of these programs have not only expertise in their respective diseases, but they have expertise in cell therapy as well. So this allows a patient to see a transplant physician or cell therapy physician with expertise with their specific disease. And that disease integration allows transplant to be optimally timed and positioned with other therapies. So there's not a bias one way or the other towards therapy. So when a patient is seen in our program, they are getting expertise in their disease in all modalities, which makes us very unique around the world. This highlights our clinical activity, and I know this is a relatively busy slide, but it highlights many of the things. We have one of the largest cell therapy protocol portfolios in the United States, with active trials in hematologic malignancies and solid cancers. We currently have over 25 clinical trials. We actually were, relative to commercial CAR T-cell therapy, we were the first center in the United States to offer both Yescarta and Kymriah for all three of their respective indications. We were the first center in Illinois to offer all available CAR T-cell products. So we have it in multiple diseases and for every indication. We were one of the first centers selected to deliver another form of cell therapy known as tumor-infiltrating lymphocytes. This is for the treatment of metastatic melanoma. And we were one of the first sites to be not only activated, but to treat patients. As a matter of fact, there's in the news today of one of our long-term survivors whose disease appears to be eradicated by this unbelievably effective treatment. And relative to gene therapy, University of Chicago Medicine Comers Hospital is one of 9 centers in the United States to offer therapy for sickle cell disease, and we are now going to have additional gene therapy for beta thalassemia in the very near future. So we're able to offer almost every advanced modality in the form of stem cell transplantation, cell therapy, and gene therapy. And this is just showing a few of the publications. As I mentioned, we have been involved in multiple FDA approvals. And matter of fact, we're likely to, there's going to be 2 additional FDA approvals in the very near future for products that we were involved, one including a first in humans that was performed at our institution. And here are just some of the publications in major journals where we have been our participants and co-authors on the papers. So just to give you a highlight of some of the distinct cell therapy trials we have at the University of Chicago, We have a off-the-shelf, what is referred to as an allogeneic CAR T cell product that we are using in relapse and refractory patients with B-cell ALL. And this is even for patients who had already received CAR T cell therapy. We have an ongoing phase 1 study in lymphoma for patients with chronic lymphocytic leukemia and small lymphocytic lymphoma that combines a standard therapy of ibrutinib, and this is a rapidly produced CAR T cell product. In multiple myeloma, we have a phase 1 study with a CAR T cell product that can be produced in 3 days. We were one of the first studies of 6 centers selected in the United States to perform this study. And as I mentioned, we have a number of solid tumor protocols, but this is a phase 1, phase 2 trial targeting the HER2 antigen in patients with relapse and refractory solid tumors, and HER2 being expressed in gastric cancers and breast cancer. So we're very excited by the ability to deliver these cutting-edge therapies to patients. A lot of this research is based upon the foundation of translational and clinical research through the David and Etta Jonas Center for Cellular Therapy. Mr. Jonas was very kind to give us a $10 million US dollar gift to accelerate cellular therapy and research. And the vision of the Jonas Center is to leverage the great transplantation, immunology, and cancer research programs at the University of Chicago and establish University of Chicago Medicine as an internationally recognized center of excellence in cellular therapeutics. And our goal is to address fundamental translational and clinical questions which currently prevent a more extensive use of cellular therapeutics to correct disease. And note that this isn't just, and when it says correct disease, this is not cancer, but we're looking to expand upon this in non-malignant diseases such as autoimmune disorders and neurologic disorders. So physically, we have what is referred to as the Jonas Center Advanced Cellular Therapeutics Facility. It supports both our adult and pediatric programs. It helps us produce the commercial CAR T cell products, but also to conduct pharma-sponsored clinical research and actually investigator-initiated cell therapy trials, and to perform preclinical development for these trials. And here is a 3D rendering. In the upper corner is Dr. Amitha Wickrama. He is the director of the Advanced Cellular and Therapeutics Facility. And this is a 4,000 square foot facility with isolation rooms which actually permit the use of viral vectors to genetically modify the cells. This is where we do our clinical with CAR T cells and stem cell products. And then we have this space, this QC space, which is actually used for preclinical development. So this will enable us to stay at the cutting edge of cell therapy research. We have 2 major projects as part of the cell therapy, Jonas Center cell therapy research. One is the isolation and use of mutation-specific T cell receptors for personalized cancer therapy in solid tumors, and then overcoming mechanisms of resistance in diffuse large B-cell lymphoma. And these have the respective impacts of potentially doubling the number of patients who receive T-cell therapies and developing safer and more effective engineered T-cell therapies, respectively. As mentioned, the University of Chicago is the cancer center of the future, and I was able to share this. This is the space where the new cancer center will be built, and it actually is advantageous because this is our old hospital here. This is known as the KCBD. This is where the research, and actually it will be connected, all of this. And why I bring this up, This estimated 633, it's actually up to about 800 million. And a majority of this will be dedicated to cell therapy. And as you can see by these beautiful renderings, it will be a very nice environment for if patients have to receive cancer care, it is to be done in a beautiful environment. So in summary, CAR T cells are now a standard practice for selected hematologic malignancies, including large B-cell lymphomas, follicular lymphoma, mantle cell lymphoma, pediatric and adult B-cell acute lymphoblastic leukemia, and multiple myeloma. Current trials are looking to move CAR T cells earlier in their respective treatment paradigms, and cellular therapy technology is rapidly advancing. So thank you very much. I don't know if there's time for any questions, but if there are, I'm more than glad to take them.
Thank you very much for the excellent presentation, Dr. Bishop. You may stop share your screen. There are a few questions in the Q&A chat box. So if you have any other questions, please leave your questions in the Q&A box. So I'll just go over one by one. The first question was, what is the benefits in stomach cancer for CAR T cell therapy? I think it's related to the solid tumor part as well.
Yes, so for and it benefits in stomach cancer. So one of the stomach, there's a couple of that HER2, that anti-HER2. There's actually a significant percentage of patients who express HER2 in their stomach cancers, and they are actually eligible to receive CAR T cell therapy. Now, this is currently remains under clinical investigation, but we've been encouraged by early results in terms of responses in stomach cancer. There's other forms of stomach cancers that have different targets other than HER2. And that's part of that project that I was mentioning before as part of the Jonas Center. So we're hoping that we can expand this because stomach cancer is such a common malignancy.
Got it. Thank you. Tanya, can you read the second question in the Q&A chat?
Sure, most gladly. The second question reads, thank you very much for the presentation. Which do you think would be the use of CAR T in refractory relapse acute lymphoblastic leukemia as a definite treatment or as a bridge to a transplant?
Oh, that's a very, very good question. That's actually a controversial question too. So the question is whether CAR T cells can stand alone and treat and cure the disease, or whether there is a necessity to, once you get a patient into remission with CAR T cells, whether you should have further consolidation with an allogeneic stem cell transplant. So this has been looked in both the adult and pediatric. Now, the pediatric population majority would argue that with Tisa-cel, that Tisa-cel by itself, once a patient achieves a MRD, or minimal residual disease negative complete remission, that they are cured with the CAR T cells. And I would say the majority, but not all, of pediatric oncologists, hematologists would say that they don't need, at least if you went to the University of Pennsylvania, they would say you do not. In the adults, we looked at it actually in the ZUMA-3 trial, and we found that the outcomes were nearly identical between patients who did go on to receive transplant and patients who did not. Now, the argument could be made that the reason that the patients who went on to get an allogeneic stem cell transplantation were higher risk. Similarly, we are participating on the Autolus trial, which is another CAR T cell product for B-cell ALL, and it's an adult patients. And we've actually looked at it in this patient population and have found that there's no difference between those who went through allogeneic transplant and those who did not. However, taking all this, there have been retrospective studies looking at commercial products, and there seems to, among those patients, there seems to favor the use of allogeneic stem cell transplantation after achieving a complete remission with CAR T cells. So I actually think that it's going to be dependent upon how deep that remission is and the risk factors for that patient, but it still remains an unanswered question at this time. I could go on for hours, and I know I'm already going on too long, but it's a controversial question.
Thank you. Thank you, Dr. Bishop. Tanya, the third question.
Sure. And in the case of using an anti-CD19 CAR-T, what do you think of the previous use of blinatumomab?
That's a good question. So that's, so sequencing is a major question. And not only with blinatumomab, but what we're finding with the bispecifics and in other diseases other than acute lymphoblastic leukemia. However, just specifically to your question about blinatumomab in B-cell ALL, there's only a slight, if you do in retrospective analyses, there's only a slight decrease in efficacy with the use of prior blinatumomab as opposed to patients who have not received blinatumomab. So in the situation of trying to get a patient to CAR T cells, you have to, acute lymphoblastic leukemia is not a benign disorder. So in our situation, we will use blinatumomab while we're trying to get a patient to CAR T cells. And again, we believe blinatumomab is excellent. It's part of the induction therapy and achieving minimal residual disease status. So in our clinical practice, we do not, we actually favor the use of blinatumomab. We don't look at it as a negative factor relative to CAR T.
Great, thank you. Another question. We are going to share the recorded video to everybody. So I'm just telling you that. The question is, in the days of medical inflation, the new technologies change lives, but the opportunity for healthcare systems to afford is reduced. How do you think we can bring this technology more affordable and available?
Yeah, I think that's a very, very important question. So the other thing that I've become more a greater proponent of is point of care delivery. And I do believe that there are devices that are relatively inexpensive that can be placed in any hospital that are capable of producing CAR T cells. As a matter of fact, the cost, again, it's still not cheap, but you could probably get down the cost of a CAR T cell product to between $50,000 and $100,000 using one of these devices. And the device would pay for itself relatively quickly if you just do a few CAR T cells a year. So I do believe that that's going to happen, and I think technology is going to permit even the most advanced CAR T cell therapy to be delivered in a greater number of hospitals. And as a matter of fact, I think that's, it's just like surgery, when the initial heart surgeries that we now think could be done in a few academic centers are now standard of care in even our community hospitals. And I think that's what's going to happen eventually with CAR T cell therapy, which would make it, again, because right now it's being underutilized for the number of patients who it could potentially benefit.
Great, great. Promising. Thank you very much. The one last question is about non-T cell activation linker as a lipid wrapped membrane proteins. Shall we consider this kind of protein as a specific target in order to use the CAR T cell therapy?
Yes, can you repeat that one more time? I want to make sure I don't,
The question is about non-T cell activation linker, NTAL, as a
yes.
lipid-wrapped membrane proteins. Shall we consider this kind of proteins as a specific target?
That's pretty advanced. And I wish I could give a fair answer to that in terms of and its expression on I mean, I know that people are investigating the use of it, and I don't know what its expression is on normal tissues. The person asking is probably more advanced than I am in regard to that, but I think that's the primary question is expression on normal tissues. But the simple answer, although I'll have to admit a moderate to large degree of ignorance. I'm familiar with the protein, but whether I can answer that fairly, is it going to be a good CAR T cell product? I don't know.
All right. Dr. Bishop, I just want to ask one last question before wrapping up.
Yes.
So what would be do you have any prerequisite or requirements for international patients to come to Chicago for CAR T cell therapy? What kind of conditions or prerequisite is required?
So, I think that the biggest thing is performance status is a big thing. I mean, we're able to do CAR T cell therapy even on patients on dialysis. As a matter of fact, we've recently had an international patient from the Middle East who successfully went through and while on dialysis. And as long as their performance status is adequate, I mean, we can take patients who even have, again, cardiac dysfunction, lung dysfunction, as I just mentioned, severe kidney dysfunction, including dialysis, but they have to have relatively good performance status. And so that's probably the major criterion that I can think of. And if they have, good family support, because they do need a caregiver support but performance status is probably the most important thing that I can think of.
Got it. Thank you very much. Well, I think it was a great presentation and great discussion. Again, thank you very much, Dr. Bishop. And I'd like to thank you again for everybody for your participation in today's webinar. If you have any further questions or are interested in any collaboration with the University of Chicago Medicine, please do not hesitate to contact us. So we will continue to provide such webinars in different clinical topics as well, and look forward to seeing you all in the next webinar programs.